My name is Humaira Ahmed. I'm a final year medical student at the University of Plymouth Peninsula Medical School. Today I will be speaking to you about our research titled Chlorine Disinfectants versus Superbugs. More specifically, Clostridioides difficile spore survival after recommended exposure to chlorine-releasing agents. There you go. This work is part of a collaborative research effort led by Dr. Tina Joshi, who is an Associate Professor of Molecular Microbiology at the University of Plymouth. And it also involves contributions from both UK and international researchers. Our aim was to look at C. difficile spore resilience to current disinfection methods within healthcare settings, with the ultimate goal of improving infection prevention and control strategies within these settings. So to provide some context about our research that I'll be speaking about today, Clostridioides difficile, also known as C. difficile or C. diff for short, it's a spore-forming bacterium that is the leading cause of healthcare-associated infections. It can cause severe diarrhea and inflammation of the colon, leading to life-threatening colitis. And one of the things about C. difficile is that it can produce spores. So these spores are protective forms of C. difficile, and they act as a shield to harsh environments. Some of the recent studies have shown these C. difficile spores that they can actually be resilient to heat, biocides, and environmental damage. And studies have also shown that these spores can showcase antimicrobial resilience properties, which is quite challenging given that current treatment plans involve antibiotics such as fidaxomicin and metronidazole. And there has been an increase in incidence of since COVID-19 of the incidence of C. difficile within hospitals. And you might have seen recently in the BBC News, the Royal Liverpool Hospital had noted down that their target was to reduce Clostridium difficile infections to 4 cases per month. However, for the past 8 months consecutively, they've failed to reach their target. So why is this happening? So where do we stand now? So the current Department of Health guidelines suggest that we use chlorine-releasing agents as a disinfectant method from concentrations of 1,000 parts per million to 10,000 parts per million. And these chlorine-releasing agents are sodium dichloroisocyanurate, known as NaDCC, or sodium hypochlorite, NaOCl. And this is for a contact time of 10 minutes for surfaces that have come into contact with these spores. There's some nice pictures of some spores there. So, like I mentioned, these 2 chlorine disinfectants, they're the most commonly used, and the main reasons being due to their availability, but also their broad-spectrum antimicrobial activity. But interestingly enough, there's not much research out there of the effect of these agents on C. difficile in particular, and we're not sure of the mechanism of action. So there is a large, significant research gap on this with regards to these chlorine disinfectants on the spores. And interestingly enough, most of the studies conducted from 1980s to 2000, so pretty much before I was born, focused on Bacillus subtilis. Bacillus subtilis is a complete different bacteria to C. difficile, which I'm speaking about today. So it really makes you question the appropriateness of basing all of the foundations of our disinfection protocols for C. diff on this different bacterium. And so it raises the question, really, are our current guidelines fit for practice? So what is the difference between these 2 bacteria? So Bacillus subtilis and C. difficile, they vary quite differently, actually. One of the biggest differences being their oxygen requirements. Bacillus subtilis being aerobic and C. difficile being anaerobic. Bacillus subtilis is a foodborne bacterium, whereas Clostridium is healthcare required. Bacillus subtilis, which our current guidelines are based on, has limited clinical impact within the healthcare setting, whereas C. difficile has been shown to be highly resistant and has been shown to possess antimicrobial resistance as well. And although both of them have this exosporium, which is the outer proteinaceous outer layer, the C. difficile has the different strains of C. difficile. The exosporium varies for each of them. And Bacillus subtilis also has different germinating and sporulation capabilities as well. So it reacts differently to the disinfectant compared to C. difficile. So one of the most critical aspects of C. difficile is its ability to adhere to a variety of surfaces. So a study conducted in 2012 by Dr. Tina Joshi and team found that 21 strains of C. difficile adhered differently to surfaces. And the surfaces that were tested were inorganic surfaces such as stainless steel and organic surfaces such as human gut epithelial cells. And there was variability in spore adherence to these surfaces, and it was found to be due to this presence of this exosporium, so that outer protein sort of coating that I mentioned, and you can probably see it on that picture sort of labelled C, and it's sort of quite a layer on the outside which can form quite a barrier. And so the graph shows here the sort of differences in sort of increase in sort of adherence to surfaces with those spores that had this outer protective layer compared to those without it. And it also highlights the importance really of testing different strains in research, because each strain, there's a huge variation in the way they react. So we wanted to see how these spores would react to the current treatment, so chlorine disinfectants. So the first chlorine disinfectant is sodium dichloroisocyanurate. So in 2017, 21 strains, we wanted to see how they would respond to a suboptimal concentration of disinfectant. So this concentration being less than what is required. So I mentioned the Department of Health recommends 1,000 to 10,000. So we tried 500 ppm, parts per million of the sodium dichloroisocyanurate. And we found that it actually increased the spore's ability to adhere to surfaces, and a lot of that be due to, we think it suggests that suboptimal concentration use can actually interfere with the way the spores can adhere and their capabilities of sort of adapting as well, which really highlights the importance of cleaning operatives, ensuring that they are aware of how to make up the right concentrations of disinfectant and whether they are sure of the concentrations that they should be using. And also ensuring that they're using the correct contact times as well. So the Department of Health has mentioned 10 minutes, and we have done more studies just seeing whether 10 minutes is the most appropriate time as well. So whilst much of the discussion in the C. diff community has been on hard surfaces, soft surfaces such as mattresses, bedding, and PPE has also played a huge role in sort of transmission of C. difficile spores. There are currently no guidelines, no EPA or UK guidelines on soft surfaces with C. difficile, which is really interesting. So we decided to conduct a study. So this study was published in 2022, and we tested whether single-use PPE could harbour C. difficile spores. And why we did this? Well, the US hospital staff were found to be not very compliant with disinfection procedures within the hospital, and they also were found to not change their PPE as regularly as they should have been. And the findings from this study were we managed to extract the most hypervirulent strain of C. difficile, so that's the strain, the 027 ribotype. And we managed to extract this from the PPE, kind of showing that these PPE single-use gowns can act as a vector of transmission for C. difficile, and the importance of adhering to the disinfection protocols and methods that we have out there. So from this, so me being a medical student, I was wondering what impact does this have on patients? And graduating soon and, being a doctor, seeing everyone around you wearing patient gowns and surgical gowns, can these gowns act as sources of transmission as well? So we conducted a collaborative study with the USA, so Adventist Hospital in USA, and we wanted to examine the ability of these spores to adhere to these surgical gowns when artificially spiked with these spores. And we wanted to determine whether these gowns could act as a reservoir for C. difficile spore transmission, and we also wanted to examine the transmission of the spores between fomites, so things such as stainless steel and hospital floor vinyl. So you can see these NADCC, so sodium dichloroisocyanurate, they're sort of in tablet form, and that's how you sort of develop it, really. So the findings from this study showed that the polypropylene gowns, they actually could contribute to spore transfer. And two types of spores were used, so both purified and unpurified, and we applied them to the gowns at different times as well to get the exact sort of idea of the recovery process. And the spores were able to be recovered from both the hospital-grade stainless steel and hospital floor vinyl. And you can see there's quite a distribution between the different types of strains used. So different strains of this C. diff bacteria react differently. So it's quite hard to know how they will react to sort of future disinfection ideas as well that do come about. And from this, we also wanted to see how they would react if we actually directly put 1,000 parts per million of the chlorine disinfectant onto the spiked surface to see, does this kill the spores? Can we still extract the spores? And we actually could. We were still able to, this really tough R20291 strain, we were still able to extract it even after the rigorous disinfection. So this is a picture, so a scanning electron microscopy of the surgical gowns, so the polypropylene gowns before and after disinfection with the chlorine disinfectant. And as you can see, there's still viable spores even when we were able to extract it, but it's interesting how you can still see it on the fibre of the gowns as well. So we thought, why not repeat this? We want to see if the second chlorine-releasing agent, so the chlorine disinfectant sodium hypochlorite, whether that would react in the same way or whether that would be better than the first one trialled. So we used purified spores from 3 strains and examined the survival to the minimum required disinfectant, which was 1,000 parts per million, as well as the maximum stated recommended disinfection dose, which was 10,000 parts per million of the disinfectant. We tested these in liquid on the surgical gowns and on the patient gowns as well. And they were spiked in varying concentrations. So, shockingly, the spores were recovered in high amounts, showing that these spores are highly resistant to these chlorine disinfectants that are used in healthcare settings and the clinical environments. Even you can see from the white bar on here that was 10,000 parts per million of the sodium hypochlorite, so the Clorox. And we were still able to get viable spores. So are the current protocols that we have at the moment, are they actually are they representative of what we should be using to get rid of this bacteria? And yeah, so the spores were both viable. So we've got the first graph being in liquid and the second one being from spiked surgical scrubs. So they are both in very high numbers. Some other work that we've been working on. So there's a lot of work in progress and a lot of studies that are being looking into the biophysical studies with universities abroad, looking into why is this happening. And like I mentioned, there's a huge literature gap with regards to, C. difficile spores and how they react to these disinfectants. So we want to answer these why questions, like how and why is this still happening, and how are the Clostridium difficile infection rates in the Liverpool hospital that was recently mentioned in the news? Why are the rates still rising and not being controlled? So we published a paper recently this year, which got international proclaim. We had universities and hospitals and researchers from all over the world tuning in to sort of see what else can be used instead of chlorine disinfectants, because they're not very effective according to our research. We are yet to explore genomic resistance, which is an area which is really fascinating to us, as we want to answer the scientific questions. And obviously this is being recreated within a laboratory setting, but we're trying to sort of mimic the healthcare environment as much as possible, and the fact that C. difficile spores can transfer quite fast within these settings. And often C. difficile, when you have an outbreak on the ward, what tends to happen is a patient has to go in isolation into a separate cubicle, a separate room, and the healthcare workers have to don PPE before entering the room and getting rid of the PPE before exiting the room as well. So the biggest thing that we want to do is we want to ensure that all studies and those that work within microbiology in the research film, that they actually utilize as many strains as possible, so we can figure out why there is this variability within the strains and how they react. And a lot of it is about understanding the biological processes of this bacteria. With the ultimate goal of actually trying to create sort of tailored infection prevention control strategies for this particular bacteria, and for other bacteria as well. So they have to be quite targeted around the research that is out there. And there's quite a lot more happening. We had Katie speak this morning as well about her research on so there's been a lot of studies about laundering processes and how C. difficile spores are surviving the laundering process and how that's not as effective. So it's great to see that research is being done in that element as well. We also want to look into wide genome sequencing as well to understand the genes involved, and also do things like long-term exposure experiments. So in terms of the new data that our team is working on, we thought, why not throw all the pots and pans at these C. difficile spores? By pots and pans, I mean chucking as much chlorine disinfectant at it as possible and seeing what happens. So we tried to do a long-term exposure experiment where we exposed these spores to 3 times, 3 rounds really of disinfectant, so 1,000, 5,000 and 10,000 parts per million of of both chlorine disinfectants. And after each exposure, we harvested the viable colonies and then regrew them to kind of see if there were any differences in the morphology of these bacteria. There are also imaging done, so there's lots of transmission electron microscopy imaging being done within the labs, and sort of Illumina sequencing and Raman spectroscopy as well to sort of help understand the sort of chemical properties of this as well. So as you can see, after the sort of 3 times serial passage with the first chlorine disinfectant, so the sodium dichloroisocyanurate, even after the 3rd exposure, spores were still being extracted, which highlights that even with repeated cleaning with the same chlorine disinfectants, it's not really going to work. It's not really working with this chlorine disinfectant. So something does need to be done. And then this was repeated again with the sodium hypochlorite, and showing again the spores were still viable. So repeated exposure is not a solution, but it also shows that there's potential that these spores they've got adaptability capabilities. So the internal mechanisms of these spores, they could be contributing into, adapting all the time. So really, in terms of the long term, are the current protocols that we have really going to be effective in the long term? And that could be in a couple of years as well, given that we've had a lot more outbreaks recently. So what is the clinical relevance of me speaking today? So I wanted to get across that we've had many C. difficile infection outbreaks within the hospitals, and we're not really sure what to sort of do to treat them. Each strain behaves differently. Even from the graphs shown today, we've got both hard and soft surfaces which can act as sources of transmission and as reservoirs really to, so it's kind of moving forward in what can we do to tailor these guidelines. The policies do need to be revisited in terms of, are the current Department of Health guidelines, which were published a very long time ago, are they still appropriate right now? We also want to, obviously there's no guidelines on the soft surfaces, so there are some guidelines in terms of the Department of Health talking about what should be used for sort of hard surfaces, sort of vinyl and stainless steel, but for soft surfaces like the gowns, the PPE and the bedding, there's nothing out there in terms of telling the cleaning operatives what to do. In order to move forward and train our cleaning operatives to ensure that patient safety is at its optimum, something does need to be done. And we also advocate for more researchers to look into more strains and sort of work together with clinicians and industry to see what we can do to kind of reduce this incidence level, really. And prevention is key. So having really strong infection prevention measures in place can really make a big difference in terms of the transmission of these spores. So some things that, a lot of questions we've had is, okay, so if chlorine disinfectants aren't great, what can we use instead? Well, some of the things that are out there people are researching is sort of the use of UV light, the use of hydrogen peroxide vapor as well as an alternative, but also looking into things like having antimicrobial surfaces, and with the patient and gowns and surgical gowns, maybe having silver embedded fibers, which silver possessing some antimicrobial properties. And the most important thing today is really the importance of keeping up to date with scientific literature. It really does give us an indication of where things will be moving in the future. So it's really important that us as researchers, but also industry and the cleaning operatives work together in terms of ensuring that we have the most optimal measures in place. Brilliant. And there's some further reading if anyone wants any homework, but I'll leave it there. Thank you very much.